All right, I believe we all are on. Again, just to welcome you to this monthly virtual that we've been doing with Diagnexia, and Ava Carr is the moderator who helps set up the system and send out the invitations. And I gather that you all would have been aware that there's a time difference in the US. We are now in the winter time, so those of you outside of the US would obviously have to adjust your times. But now that you're here, you're obviously aware of that. And Ava said to me that the system does adjust it and give you a correct local time. So that's good. If you've not been with us before, just a brief introduction. We have this once a month. The next meeting would be the same time, 1 o'clock my time. So December 17th, if I forget to tell you that. And this the same system is used every time. Is I show you a slide, I give you a history. These are all scanned slides from my own practice, and I share the morphology with you, and then you would give me your differential or questions or investigations in the chat group, and I will try and answer as many as I can. So that seems to work most successfully, rather than unmuting and getting through that process. But the chat seems to work very well. So I have my chat open, and we can take that from there. So the first case I put up here for you now is a 50-year-old woman, and this is an endometrial curettage. So here we go. This is what we received, and I saw this a couple of years ago with from one of my GYN colleagues who showed me this case, and I will share the morphology with you. Well, just on low power, you can see that pretty much sort of looks almost polypoid, but I don't want to put any ideas into the diagnosis or the differential diagnosis, but just show you the morphology. The section's a little thick, so I have to go closer to show you better morphology, which is similar in all of the sections. Here you can see sheets and sheets of these cells. They are small, round ovoid nuclei, and some of them, as you can see, have eosinophilic cytoplasm. There are no mitoses that I can see, but in this field, you can see most of them appear to be arranged largely in sheets. But as you drive around, you do see different morphologies coming up, and I'll just point them out to you as we go through. There's some areas where they look like cords and nests, and I'm going to try and find you these. And there are even a few. Let's see if I can find you the cords and nests. Yeah, you can see some. Okay, here we're going really high power just to show you some of these arranged in cords, some of them arranged in nests. There's some nests, a nice little nest. And it's subtle because the tumor itself is quite cellular, but you can appreciate different patterns in different areas. In some areas, they are even, I'm trying to find you a glandular structure. That's a vessel there. Little nest is another nest, and little cords as well. And there we go. So we've got a suggestion already in the chat, which is a mesonephric-like carcinoma, and that's a good thought. So this was an endometrial curettage. So as you know, mesonephric carcinomas were first described in the cervix. In those days, we used to use CD10 to identify them, and a background of mesonephric hyperplasia. But these days, they've been described in the endometrium, and then they've also been described in the ovary. So hence, it's mesonephric-like carcinoma. Epithelial it is, you're correct. So if you use keratins, these are positive for keratins, just to get that into that differential diagnosis. There's another suggestion of a high-grade endometrial stromal sarcoma. Yes, you would consider that in the setting. In your differential diagnosis because of the morphology. Now, high grade at this point, I would be a little reluctant to just go down the high grade group. I'd want to see more mitoses and atypia and pleomorphism, but let's keep it at endometrial stromal sarcoma. And if you wanted to go down that route, then again, CD10 is a useful starter. Some people use cyclin D1 as well. So that would be an option. I've got a third option here. Hi, Florence. Nice to hear from you. Utrost. You all know what utrost is. Uterine tumor resembling ovarian sex cord tumors. And that's an excellent suggestion, given the heterogeneity of the morphology. I said there were cords and nests, and there were even glands. I've given you that mesenchymal, I've given you that keratin is positive. Would anybody else like any other markers on the suggestion of utrost? Okay, we have the epithelial markers positive. You can use the hormonal markers, ER, PR, they're variably positive. But the other two groups of markers that I like to think about when I'm thinking of utrost is mesenchymal markers. And in this context, we're thinking of smooth muscle markers. So Desmond is also positive in a good percentage of utrosts, but also the ovarian sex cord stromal markers like SF1, steroidogenic factor 1, and inhibin. Inhibin is another marker. So having all three markers with this kind of varied morphology is useful to make that diagnosis. And yes, I did call it a utrost. You're correct, Florence. This was a nice example of it. I have not resorted to molecular confirmation because seeing the heterogeneity of the morphology as well as the polyimmunophenotypic in having the mesenchymal, epithelial, and sex cord stroma, I found useful to make that diagnosis. But if you had to resort to molecular analysis, you can, whilst I'm talking, I'm looking for these spindle areas just to show you that they can be spindled as well. So as you drive around these, you do find a varied morphology. Yes, you have to consider stromal tumors, and yes, you have to consider carcinoma as well. But again, thinking about both the morphology as well as the heterogeneity of it, you've got to bring in utrost as well into that differential diagnosis. So I was mentioning the molecular NCOA2 is it the gene that's fused in that? I think it fuses with ESR. And the other gene that's involved is GREB, G-R-E-B. Now, those are fewer tumors that have GREB, and they seem to be more recently papers showing that they have a different prognosis as well. But what I do, yes, we know, yes, PCOMA does come into the differential. I may have told you this in the past, but when I see something that I do not know what I'm looking at, if it's not smooth muscle tumor, if it's not endometrial stroma, if it's not carcinoma, then I ask myself in the uterus, well, what am I looking at? Is this a utrost? Is it a PCOMA? Or is it an IMT? Those are the things I keep at the back of my mind because these have now evolved in the last 5 to 10 years as definite well-recognized tumors in the uterus. So you'd have to do the appropriate markers in that context. You can get sclerosing picomas, you can get spindle cell picomas. So the best way is to do your muscle and myomelanocytic markers in order to rule that out if you're considering that as a differential diagnosis. And then picomas, as you know, does have a molecular profile that's different or signature from utrost in that it involves a TSE1, TSE2, and then a subset with TFE3. There's a subset as well. So myomelanocytic, my screening tool in that regard is typically the muscle markers, Desmond, actin, as well as HMB45 and melanae. So the diagnosis, yes, is utrost, and all three markers were positive. The mesenchymal markers, Desmond, actin, SF1, and inhibin, as well as epithelial markers, keratin. So a nice example of a utrost, and also to remind you that these can be aggressive. There was a recent paper from the MassGen showing that these can recur, and not all of them are benign. So be aware of that. You'd have to do a risk stratification of the uterus. And there is a paper out there in AJSP on the risk stratification, characterizing or giving some clue to the clinical behavior of these tumors. The last thing I want to tell you about this, there's a nice paper in Advances in Anatomic Pathology. Okay, you may not get this, so you may have to get it through your library or your university. Advances in Anatomic Pathology, there's a nice review on the risk stratification of these uterine tumors that we're talking about, utrospicoma and IMT. So get that. That's your one-stop paper for risk stratification of all the unusual tumors, and that's very useful. So print that out and keep it in your files. Any other questions or comments? Okay, let's move on to the next case that I have on my list. There we go. All right, so this is skull-based tumor, 66 male. And it came to the head and neck sign out. So our head and neck surgery, ENT surgeons would remove this. And you can see that the entire slide comprises tumor. There's some necrosis there and hemorrhage. But let me go down and show you the tumor itself, okay? Just to point out these morphology, the architecture, which you can all see, okay? Nice fibrovascular cores and these multi-layered cells around these fibrovascular cores, okay? Sort of sinuous papillary structures, if you will. And then here as well, much more trabecular. But let me show you the morphology, okay? Small, dark blue cells. Some of them have, you can see, cytoplasm. I was going to say it looks pink. Some of it does look pink and eosinophilic. Others look a little more less pink. Okay. So any thoughts you have? Skull-based tumor, 66 male. Looks pretty similar throughout. Here it's more a sheet of tumor cells, some thick wall vessels. And here you can see sinonasal mucosa, just to show you some normal looking sinonasal mucosa. And that's sitting directly on bone, okay? So it is sinonasal, if you will, but it's skull-based in that it's in that location. So surgeons like to use skull-based tumor, base of the skull, but it's truly sinonasal. Here, looking away, hemorrhage, necrosis. Nope, not worth showing you that. But here you can see these. Okay, anybody wants to take a stab? Go ahead. Any investigations that you want to start with? Happy to go. Or if you have a differential. Okay, we're getting small round undifferentiated sarcoma. That's a great start. So it looks like small round blue cells. In this setting, Tapan, you think typically small round blue cell sarcomas, you have to think about Ewing's in this context, and you have to think about the adamantinomatous type of Ewing's, which you know is diffusely keratin positive as well, but also carries the same translocation as Ewing sarcoma, EWSR1 and FLI1. So in those instances, I typically use CD99 as a screening tool for that round cell sarcoma, Ewing sarcoma, and you could start with that. Before I give you the result, I have another differential esthesio-neuroblastoma. Okay, those are olfactory neuroblastomas, and it's a good site because skull-based tumors. And you'd want to do your neuroendocrine markers, and we've talked about this before, but I typically do all three neuroendocrine markers that we have, which is synaptophysin, chromogranin, and INSM1. So those are good markers. INI1 deficient sinonasal cast. Yes, these have been well described. That's SMARCB1. Remember, those are the chromatin remodeling proteins, and loss of or mutations of these genes or deletions of these genes results in loss of these proteins. So the immunohistochemistry that you perform for SMARCB1 and SMARCA4, which is BRG, and INI1, as Shaheen has put it. Shaheen has put it on the chat, INI1 deficient. So in that context, when I'm doing INI1, I always do BRG as well. So I do both SMARCB1 and SMARCA4. And again, before I give you those results, these are all good differential diagnoses in the context of these small round blue cells that you're giving me. I do have a way in which I try to remember these and how to recall it. I'm going to just put it in the chat. Mr. Okay, this is just my own component that I use, right? So SLEEP, sleep. So the original is from Dr. Barnes and Dr. Thompson. These are famous head and neck pathologists. You know, if you go back into the literature, you'll find their names. Dr. Barnes was prior to Dr. Thompson, Lester Thompson. But there was a nice review in Modern Pathology following the USCAP long course, and in that they used Mr. Sleep. Okay, the hint is mine. I put the hint, and I'll come back to what that means. Some people who have followed this conference would know about it, so I'll just put that in brackets. But the original Mr. Sleep goes back to Dr. Thompson, Lester Thompson. He mentioned that in that paper in Modern Pathology. So that M stands for melanoma. When you're looking at small round blue cells, R is rhabdomyosarcoma. S refers to squamous cell carcinoma, sinonasal, undifferentiated, SNEC, sinonasal, neuroendocrine, and SMARC. And we've covered SMARC already. L is lymphoma. E is esthesia neuroblastoma, which has been put in there by Joe Way. And P is pituitary, which the second E is Ewing's, and P is pituitary. So the Ewing's, of course, all of this has evolved now because there's the adamantinomatous ALES Ewing's, and I talked about that earlier. That is diffusely keratin positive. Also has this abrupt squamous differentiation, peripheral palisading, but it has the same translocation, CD99 diffuse membranous positive. This is CD99 negative. Okay, so we have a panel that can address all of these differential diagnoses. Oh, I didn't go through the HIND. So H is for the HPV associated multiphenotypic sinonasal carcinoma. I is for the IDH rearranged carcinoma. We're talking about small round blue cell tumors in the sinonasal tract, and this is purely for these tumors. N is NUT. N is NUT. There you go, Fernanda. That's NUT. Yes, correct. NUT carcinoma. Not to forget that. If you have the antibody, it's good. D is DECAF. DECAF is DEK, AFF. Those two genes fuse to be the molecular signature of these recently described carcinomas in the sinonasal tract. I'm not going to go into any detail. There's some good papers. The good one there by Dr. Bishop about 3-4 years ago, or Dr. Lewis. I think it was Jim Lewis. Yeah. And then E is the EGFR-related carcinomas. There's a nice paper in Verkovs this month, actually, from Atlanta, Srivastava. And then S, we went through all of those. So if you follow this, which is a useful way to recall all of these small round blue cell tumors, let me address. So SMARC coming under S, both BRG and INI1 are intact. Okay, so when we use these antibodies, I don't talk about positive and negative. I talk about deficient or intact or absent or present. But those are the terminologies. Positive and negative are confusing to surgeons who read these reports. So both of those were intact, BRG and INI1. The neuroendocrine markers were negative. Okay, so that would be all three neuroendocrine that we talked about. CD99 is negative. Did I resort to Ewing sarcoma gene probing? No, I did not. And then NUT was negative. So we have a nice NUT antibody. Remember that that also has a fusion nut fusing with BRD. This was first described from the Boston group. I think it was Dr. Fechner. I stand corrected. Stand corrected. Anyway, anybody want to guess what this? They have given you all the differentials there. Anybody want any other stains to probe that those group of tumor that I've given you? That any thoughts? So the carcinoma epithelial markers are negative. DECAF, no, the epithelial markers are negative. So melanoma, there we go. There we go, Javeria, yes, melanoma. This is melanoma, and the reason I'm being so difficult in giving you the answer is you have to consider melanoma in all sites of the body. Think about S100 SOX10 and the melanoma markers. Here, if you think of Mr. and this is mine in sleep, the melanoma is number one there, right? M for melanoma. So in thinking about that, always consider melanoma. This literally looks papillary, right? I was showing you this looks papillary, and that probably what made you feel a little resistant to considering melanoma. But these pseudopapillary structures, because of these loosely cohesed cells and these islands break away with their fibrovascular cores, gives you this sort of pseudopapillary look. Now, I'm fortunate, but my neighbor next door to me is Dr. David Elder. He's the editor of the WHO Skin Pathology. And he once said to me that melanomas can give you all sorts of morphologies and architectures. So this is a nice example of a papillary or pseudo-papillary morphology. So keep that in mind as well. Okay. Yeah, that didn't come to you, did it? There, I wrote it out for you, but I forgot to send it. There we go. My apologies, but melanoma. Okay. Any questions or comments on that? I mean, in thinking about these small round blue cell tumors, the only way I can recall all of them is to sort of go through that and try and work it out. We do have a panel in our immunos that addresses all of these. Okay. Any questions or comments on that? If not, I can take you to my next case on this list. This is a 54-year-old male. This came from one of our sister hospitals. We have 3 hospitals in the city in Philadelphia, and this came from one of the hospitals. This was in the sinus fat of kidney. It was called kidney biopsy. It was called kidney biopsy, but it actually was in the sinus part of the kidney. I don't know how they got to it, but anyway, it was when you go into the radiology, this was actually from the sinus fat area. So I'm going to go and I'll just show you the low power so you can get an idea of the whole scan there, right? And then we'll just study it from one end and just to show you the morphology. I'll go on high power. There's a bit of hemorrhage there. I just want to show you higher power where you can see this intense vascularity, interconnecting vascularity. And then here you can see this myxoid matrix. Now, many of these cells here, and I'm going on high power deliberately just to show you between the vessels forming this interconnecting pattern, if you will. You can see these plasma cells and lymphocytes. So these are inflammatory cells in between. It's a myxoid matrix. There's a nice gray myxoid. Yeah, chicken wire. That's a fairly good start. Chicken wire myxoid liposarcoma. I didn't want to use the word chicken wire because that's what it implies. In SearchPath, we have all these terms that we use, which imply certain diagnoses and so if I use chicken wire, then it implies myxoid liposarcoma. But we'll start off with that differential diagnosis. And I'm going to show you the entire core as we go down. You can see more of this inflammatory component with this myxoid matrix. Okay. Now, there was a nice paper in AJSP, the one of the authors, not the first author, but one of the authors is Dr. Shah, Rajal Shah. I remember that name because he's a good friend, colleague that I know. So I remember his name for this. And one of the terms they used for this was this pseudomyxoma, pseudo-inflammatory mass. So an inflammatory myxoid mass that was used for these lesions, and they describe a cord. I forget how many cases there were, but AJSP, Shah, myxoid inflammatory mass of the kidney. This will come up. There is another perinephric myxoid mass that Dr. Fulp described. So don't confuse that with this one. The one that Dr. Fulp describes is around the kidney. It's a perinephric mass. And it's similar in morphology with this myxoid material and vessels and inflammatory cells. But in that context, you have to rule out D. diff liposarcoma. So MDM2 is mandatory in that context. This now is in the renal sinus fat. And one of the things of this paper where they talk about this myxoid pseudomyxoma or pseudo fibromyxoid tissue is that many of these are associated with carcinomas. And so that is the trick to this, is that you have to look very carefully. And now I'm going to show you areas very closely, very carefully, and you'll see. Myxoinflammatory fibroblastic sarcoma would be something that's typically in the extremities. I mean, they were first described in the acral distribution, and then they've been described in more proximal areas. So I'm not sure that they've been described in viscera, although I think there may have been a paper recently, but typically when I think of MIFS, as it's abbreviated, MIFS, I think of extremities. Inflammatory myofibroblastic tumor, yeah, that's a good thought. It's a good thought. But I want to draw your attention to these islands here. Now look at these areas. Okay, look at those areas in contrast to the surrounding areas. And then I just want to show you a few more of those areas. Myxoid AML, angiomyolipoma. How about this area here? Yeah, those are the D. diff lipo I would consider in the perinephric ones. This is more in the sinus, renal sinus fat. But I want you to look at these areas here. Any thoughts on those areas? Yeah, there's more of these. Yeah, yeah, you can see this whole area here. See that? Okay, we got another angiomyolipoma. How about this area here? There we go. There we go. We're getting it now. Clear cell carcinoma. Yeah, exactly. Nest of clear cell carcinoma. Thank you. For the moment, I thought I was being a little delusional there. But anyway, if you do a keratin, these light up. These islands light up here. Okay. And these are all keratin positive. Yeah, you can see a few more here on this side. I'm sure you'd all have got this, but I needed to approach it with that fibromyxoid pseudo tumor approach, so that when you see that in the renal sinus fat, you always have to rule out a carcinoma. In fact, that paper says that up to about 80% of these have carcinomas associated with it, and it can either be renal cell or urothelial. So we got this, like I said, as a referral from the outside, with a mesenchymal differential diagnosis. And these are clearly epithelial islands. These are Pax8, and stains I like to do when I'm thinking about a clear cell carcinoma is Pax8, keratin, CK. Well, I don't necessarily do CK720 because they're typically negative, but I like to do the carbonic anhydrase 9, CA9. I like doing that, so that's my go-to panel for renal cell carcinomas. I'm not going to go through the entire 22 or 23 renal cell carcinomas. You can all read about it in the WHO. But suffice to say, go to that paper by Dr. Shah, Rajal Shah, AJSP, AJSP, RAJALSHAH, and punch in I think pseudotumor, renal sinus pseudotumor, mixo-inflammatory or mixoid and inflammatory. That should bring it up. If you Google that with that name and that journal, that paper will come up. It was 2023, so it's a couple of years old, but it's also okay. But also don't confuse that with the pseudotumor, the mixoid pseudotumor that Dr. Falk described, which is perinephric, and I think that was in modern pathology. And in that context, you have to rule out D. diff liposarcoma, but that entity should not be confused with D. diff. And the only way to separate them is with MDM2, I'm afraid. So you'd have to resort to either antibody or fish. Okay, so pseudotumor or mixoid and inflammatory, but here you go with renal cell carcinoma embedded in the tissue. Okay, any questions or comments on that so far? All right, let's move on. Next one I have is an interesting tumor. Let me just back up on low power. This is on the left buttock mass, 7 centimeters, and it's a young man, 23, male. So here's the low power. And here, just to give you some anatomical arrangement of where the tumor is. You can see the epicenter is sort of deep dermis subcutaneous fat. Here's the epidermis. Okay, so it's left buttock mass, and here's the subcutaneous fat. Okay, on low power, you can see it's vaguely lobular. All right, and then I'll take you on high power just to show you what this looks like. It's just some foreign body giant cell reaction there, maybe in a previous biopsy. This was a resection that we received, and here is the morphology of the cells. Is it specific subtypes? No, it's renal cell carcinoma and urothelial carcinoma. I'm not aware that there were subtypes, specific renal cell subtypes that are related to that stroma in the renal sinus fat. But check the paper. It may be. I cannot remember that. For me, it's if I see a myxoid pseudotumor in the renal sinus fat, then I want to rule out carcinoma, either urothelial or renal cell carcinoma. Okay, yeah, I'm not aware of subtypes. Good. Thanks for that question, Javeri. I don't know the answer, but all right, coming back to this 23-year-old man, young man with a buttock mass and lobules, vague lobules with this pretty almost uniform. There's mild pleomorphism and there's nucleoli as well. So you can see nice nucleoli. And the cytoplasm in this field looks clear to pink. We've got a suggestion here of an adnexal tumor already. So spiroadenoma, eccrine spiroadenoma. Yes, they are lobulated. They have this intertwining epithelial ductular structures. This is just sheets and sheets of cells. Everywhere you go, it shows this same morphology, open chromatin, more vesicular with nucleoli. And you can see the nucleoli. The reason I'm pointing out the nucleoli will become evident as we look at more and more of this tumor, okay? I'm looking for some areas where the nuclear morphology was. Here's mitotic activity. You have to believe me that those are mitoses, really. But there are quite a few mitoses. Clear cell sarcoma, okay. I like that. I like that. Clear cell sarcoma is his age is right, typically in extremities. And this one's superficial as well. They can be superficial. They can be in any planes, actually. They can be more superficial, deep, associated with the ligaments or the fascial planes as well. And you all know that clear cell sarcoma demonstrate the same melanocytic markers, S100, SOX10, HMB45, and melon A, and they have a distinct molecular profile as well. So clear cell sarcoma is the is the EWSR1 and CREB family. That's the so the let's get the clear cell sarcoma out of the way, because we all have melanocytic markers. They are all negative. All right. I've got alveolar soft part sarcoma. When I think about that, I like to see large pink cells with large nuclei, much larger than these, with prominent nucleoli. But that's a good thought. And if you're concerned about that, the TFE3 is a good antibody to start off. It should be nice nuclear positivity and diffuse. That can be difficult to interpret, so be careful of that. There's a seminoma here. Okay, we have to think of all possibilities. And that's a good thought, given the cytoplasmic membranes and the clear cytoplasm. These cells are epithelial negative, keratin negative, and germ cell markers were negative as well. So SALF4, SOX10, I beg your pardon, OCT3-4 and SALF4 were negative for seminoma. Now, there's another, for the spiroadenoma, epithelial markers were negative, alveolar soft part, metastatic germ. Okay, we just addressed that. I like epithelioid sarcoma. You have to address that as well. And you all know that those are keratin and EMA positive, and I've already given that out, that, excuse me, that keratins are negative, give you EMA is negative, and CD34 is also negative. So we'll get that triad of markers for epithelioid sarcoma. That's what I like to do. And then, of course, you can also, if you have INI1, which I think is, necessary in 2025 to make a diagnosis of epithelioid sarcoma, and those are lost SMARC-B1. Let's see, I think I've covered everything that have been given. I like all your differential diagnoses. And then there's nodular hydranoma. We addressed that with the spiroadenoma with the epithelial markers being negative. Oh yeah, always keep weird melanoma in mind. And again, that was addressed with clear cell sarcoma, because we said that the melanocytic markers were negative in that context. Glomus tumor, that's a very good thought. It's a very, very good thought. You can do glomus tumors that look diffuse. They don't all necessarily show the nice arrangement around vessels, and they can be sheet-like as well. Actin is positive in them. You can get some Desmond positive, and they do have some interesting molecular analyses. I can never remember whether it's notch or pitch, but I've not resorted to that to make a diagnosis of glomus tumor. But that's a good thought. That's a good thought. So the myeloid markers are negative. I should mention that there is an emerging group of glomoid tumors that you should always think of. GLI1 rearranged or amplified tumors. Those have a glomoid morphology. And there's also some glomoid tumors that have PDGFR mutations as well. So there is these publications, small series that are emerging in the literature. So it's just kind of watch and wait and see how those evolve. So that's just glomus. Testicular tumor. Well, in his age group, you'd have to consider the seminoma, and with this morphology. And we've already addressed that. That's negative. Myeloid sarcoma is a very, very good thought. I mentioned earlier that CD34 is positive. You'd expect that to be positive in myeloid sarcomas. But that's a good thought. They can occur in soft tissue, and we've seen them in soft tissue. I recently saw a nice one in breast. What makes me think of myeloid sarcoma when I'm looking at these cells on high power? That's a very, very good thought, is to look for the eosinophilic metamyelocytes. Those are immature eosinophils with single nucleus and the granules. And that's the one I've always found to be useful, particularly outside of the bone marrow. I don't do hempath, but we do get these in that that might look like one. That's a very good thought. Very good thought. I must say I admire the myeloid sarcoma. The only glomoid tumor I remember is gastroblastoma. Okay, so there's you'd have to Google GLI1 rearranged tumors. There's some good reviews in the literature. The name is just blanking me. There's a nice one, Clothier, CLOTHIER, in one of the clinics. There's a nice GLI1 rearranged tumors. They do not all have mallet. Gli1 mallet, as Tapan has put into the chat group, is sort of more quote unquote specific for gastroblastomas. Those occur in the stomach. They're biphasic. They can have synaptophysin, and that fusion partner gene is characteristic of gastroblastoma. But there's a whole range of Gli1 rearranged tumors, which are predominantly mesenchymal, but you can also get epithelial. So you just Google that, and there's a lot of papers out there and review papers as well. Gli1 can either be rearranged, i.e. fusion, or amplified. Having the antibody and a gene is useful for that. Yes, it is typically biphasic, Omar, correct, the gastroblastoma. But those are unique to the stomach. I'm not aware of them being described outside. Correct me if I'm wrong, for gastroblastoma. And I think, more and more people are thinking that maybe belonging to the Gli1, but I don't know the answer to that. Okay, yes, they are very rare. So here we have then, nobody has said Ewing sarcoma, which I'm happy with because the cytoplasm is not quite right for Ewing sarcoma, and the nucleoli are not right for Ewing sarcoma. So these can have nuclear pleomorphism as well. And DDIF SFT, that's a good thought. That's a very good thought. They can have round cells. So here's there's a nice paper actually. I think it was September. AJSP, my good late friend Dr. Fletcher is on that paper. And you can read about the DDIF like SFTs in there, and they talk about loss of CD34 and loss of STAT6 in the dedifferentiated areas. So be careful, because if you get a needle core biopsy, you may not see the typical SFT areas to make that diagnosis or help you make that diagnosis. In their paper, there was a small subset that did not have usual SFT morphology. So yes, that would be a good thought here. And like I said earlier, CD34 was negative and STAT6 was also negative. That's part of my panel in looking at these. So, but because it's DDIF, it can lose both those markers, and you would then need to resort to STAT6 NAPB2 with next gen sequencing, because those genes are so close together. You cannot use FISH. It's an inversion. I'm not a molecular pathologist and I don't know much about that, but I know that FISH won't work for STAT6 NAPB2, NAB2. Synovial, you can get a round cell synovial. This one has too much of cytoplasm, but I've seen synovials with abundant cytoplasm. So that would be a good thought. Is age would fit with that. And again, if you have the antibody to the SYT, SSX, that's useful. They work very well. And so that would be. Otherwise, if you have FISH and you can probe for SYT, that's the other way around it. We did do the SYT FISH analysis in this and that, and that was negative as well. We did the WSR1, as I recall, and that was negative as well. We were just getting our FISH analyses out of the way. But ultimately, we sent this off for sequencing. And I'm going to tell you why and what I queried, because I also did a WT1. Okay, not for mesothelioma, but for sick ducts, CIC ducts. So sick ducts is one of those atypical Ewing, I'm just putting it in there, DUX, atypical Ewing group of tumors. And the only way really to be confirmatory is to sequence it to demonstrate those fusion genes. Ducts is not always a partner. There are you can get other partners as well. I say sick, some people say chick. But where does this fall in the scheme of undifferentiated sarcomas? The new WHO has it very well outlined. You can look at it there under the undifferentiated sarcomas. But when I think about it, I think of the prototype Ewings. You always have to start off with the prototype Ewings, which has the EWSR1 rearranging with Fly1, and that's always a start. And those we considered as the gold standard when it was first described in the 70s and 80s, and and the fusion genes were described, and then CD99 came around. Those are useful for the classic Ewing sarcoma. And then don't forget the sinonasal one we talked about earlier, ALES, adenomatoma-like Ewing sarcoma. Those are diffuse keratin pores. So as people observed these tumors, they noticed there were a group of what they call atypical Ewings. They were round cells, but they were not classic Ewings, and this one falls into that category. You can even have nuclear pleomorphism, so that's helpful not to mistake it for Ewings. And sequencing then emerged, and these tumors were sequenced. So under the group of atypical Ewings comes the sick ducts, and the other the B-core rearranged tumors. So these may be rearranged, they may have a mutation, or they may have ITDs, internal tandem duplications. So that's the atypical Ewing. So you have the Ewings, then the atypical Ewings group, and these are the two, to my knowledge, that fit into this category, and you'll have to use sequencing. You do get antibodies to CIC and B-core, but I don't know about the specificity, so I can't comment on that. We would send it off for sequencing when we reach the point of, okay, this is an undifferentiated round cell sarcoma, FISH is negative, let's send it off for sequencing. Then there's a third group that has emerged in more recent time, more in the last 5, 6, 7 years, which is still with the EWSR1, and they call it the EWSR1 non-ETS, because ETS refers to Fly1 ERG, which are the classic genes for Ewing sarcoma. So this group has been referred to EWSR1 non-ETS. Let me just type that. I just discovered today that I can EWSR1 non-ETS. So this group of tumors now has emerged and is being widely recognized. And again, it's because of the next-gen sequencing, but they do have a unique immunophenotype. And the immunophenotype that I think about here is more sort of a myoepithelioid. So the myoepithelial markers, think of all the myoepithelial markers, they are variably positive. Not all of them are positive, but they're variably positive. Things like actin and P63 and GFAP. And just think of the myoepithelial markers in that context. They're typically lobular, and they have a fibrous septae around them, around the lobules, and they can be myxoid, strands, cords. So that's the EWSR1 non-ETS. And there are two fusion genes for the ETS one. One is NFAT-C2, that's one. And the other is PATZ1. So those are so it's EWSR1 NFAT-C2, EWSR1 PATZ1. So those are the two. Again, if you've got EWSR1, remember now, this is now a promiscuous gene, because unless it's Ewing sarcoma, where you have classic morphology and diffuse CD99 in the right setting, all the others, if you're getting EWSR1 and FISH, you got to get the partner. You cannot make a diagnosis. You got to find out what the partner is. Look, we've already got 2 partners here that are promiscuous in that context. Last week or the week before, when I last met with you, we talked about the EWSR1 with the Krebs group. Somebody asked me for a review. I did find something close enough, but not the best one. But anyway, I'll try and get you that paper. But we talked about the Krebs, EWSR1 Krebs family, which is Krebs1, CREM, and ATF. And there's about eight or so of tumors that belong to that group. And again, you need morphology, immunophenotyping, and then molecular analyses to confirm diagnoses. So that's just my approach to undifferentiated round cell sarcomas and how I approached it. This is a sick ducts, and I promised you that I was doing a WT1. WT1 is positive in these. So be careful. The WT1 most of us have, but the WT1 we use for mesothelioma and serous carcinoma of the ovary, and then the sick ducts. It's the N-terminal WT1, because there's a C-terminal, and that's positive in desmoplastic small round blue cell tumor. So be careful. Don't try to use the N-terminal WT1 for a case where you're querying desmoplastic small round blue cell tumor. And those are also polyphenotypic epithelial and mesenchymal. And WT1 is useful there as well because that's EWSR1 and WT1. So there you go. There's another, lesson for promiscuous EWSR1. But in that context, if you have good immuno and good morphology and good setting, you can make that diagnosis. You can make that diagnosis. And if you have fish, it's nice to get the fish to confirm that. We've seen a couple over the last few years of it. Any questions or comments? I'm doing too much of talking here today. Anything? No? Everybody's quiet and silent. All right. How are we doing with time? Let's see if we can get in another tumor. I don't want to put in something that's too complex, and I'm trying to look for something that's fairly straightforward. All the cases that I choose and keep for these sets are just intriguing and unique and rare, and I enjoy putting them in here and enjoy talking to you. Let's give it a shot and let's see how it goes. This is the next one on the list. So I'm not picking any particular one. Come on, 4900. I cannot find it. I thought it was here, but it's not. It's not. Oh, there it is here, right at the bottom. Don't know why I got an extra 34 there. All right. This is a case I got from my good old friend who's a hematopathologist, Dr. Adam Bag. And he received this as a consult. And so it was from the outside. And these are neck lymph nodes, lymphadenopathy, head and neck. This is a 36-year-old man. Okay. And here you can see the capsule. I'll just stay with one lymph node. I don't have to go through all of them. It's a while since I looked at this, but let's see. There's a capsule. And you can see lymphoid tissue here. Some of these look like germinal centers, so I think. But what you already spotted, all of you out there, are these pink structures here. All right. I know you all know what these are. Okay. So there's those pink structures, and then between those pink structures, in which you all know what they are, if you look carefully, and that's why I didn't want to do something so quickly, or try to do it quickly, because you cannot find what you're looking for. Intermittently, there are some large cells. Yeah, there's one here. Okay, there's one here. Yeah, you can see these large cells. It's getting a little blurry on higher power, but look at this large cell. Okay, you can see very distinct nuclear membrane. And yes, those are granulomas, correct. Those are granulomas. But then in between, in the lymphoid stroma, there are these large cells, prominent nucleoli. Here's another here. Here's another here. And then now they start to pop up. You can see them coming up quite frequently. Large cells, prominent nucleoli, vesicular chromatin, and irregular nuclear membrane. There's a nice one there as well. Okay. So yes, there is a granulomatous lymphadenitis, yes, but there are these large cells in between. And my good friend Adam Bag did a host of immunohistochemistry on this. Okay, which is where the intrigue comes in, because this is a fascinating case. And he did here's another one here as well. You can see these large cells. Prominent nucleoli, distinct. I can see Hodgkin's lymphoma, yes. I don't know what the HI is, Javeria. What's HI? What are you thinking of HI? I don't think about hempath these days, so you can tell me what you mean by HI. Okay, here we go. There's more of these bigger cells. Okay, so a granulomatous lymphadenitis with the intervening lymphoid stroma. There's a nice one here. With these large cells, prominent nuclear membrane, and vesicular chromatin. Okay. Any thoughts? I've got here Hodgkin's lymphoma. Apologies for, yeah, Hodgkin's lymphoma, correct. Okay, fine, got that. Germ cell tumor, it's a good thought. Seminoma metastatic. I've seen it in the neck. I really have. I remember seeing a case in the early 90s in Johannesburg, patient with seminoma metastasized all the way up to the neck. And we asked them to look at his testes, and sure enough, he had a mass in his testes. So these are negative for keratins and germ cell markers, seminoma. But yes, you nice thought. Uh, there's these big cells, prominent nucleoli. And Hodgkin's markers are negative. My good friend Adam Bagg did all of the Hodgkin's markers, CD15, CD30, and those two are negative. So he brought it to me after he'd done a whole lot of stains. But there was one stain that was useful for the identification of these big cells. And it's not Hodgkin's, it's not germ cell tumors. Those are good. HHV, I like that. Nozuko, yes, I like that. My my good friend in Cape Town showed me a very nice case recently with HHV8 viral inclusions that was referred to him as a potential malignancy. I'm forgetting the location, but he showed me a nice one. This is not that, but I did not do HHV86, and I don't have I don't have that marker. But the one we have was positive. Rhabdo meaning rhabdomyosarcoma. Oh, it was my case. You sent it to Professor Govender. Okay, nice. Small world. Small world. All right. Melanoma. Yeah, your good old friend. Always think of melanoma. So I'm going to give you some homework now because my time is up and your time is up. I don't want to keep you. But think about this. The granulomatous lymphadenitis with these intervening large cells. I'm going to give you a clue. Okay. The paper you want to look at is from John Chan, J-O-H, John Chan, and AJSP. He talks about this and the context with granulomatous lymphadenitis as a subtype of what we're talking about. All right. That's what I'm going to give you. Look at his papers. There's another paper he talks about which has eosinophils, a lot of eosinophils that can mask the actual nature of this neoplasm. So look at his papers, and I'm talking early papers around 2008, 2012, thereabouts, HASP. And we'll talk about it the next time. I promise we'll start off this next time. Let you think about this one. Okay. Nice to have you all on board, and thank you for your contribution and participation. Enjoy being with you guys. Thank you, guys.